So we now move on to Chapter 8 and Chapter 12. And Chapter 8 is on psychotherapeutic drugs, medication for mental disorders. The learning objectives for the chapter to discuss what is meant by concurrent disorders and why we are seeing an increase in Canada, to discuss why many professionals oppose the medical model of mental disorders, to describe the classifications of anxiety disorders and phobias, psychosis, and mood and depressive disorders, to explain how the model by Hebb characterizes the progression of panic disorder and its implications for pharmacotherapy, to explain the historical context and the importance of the discovery of phenothiazine antipsychotics, to list several currently available antipsychotic drugs, distinguishing between typical and atypical antipsychotics, and to discuss theories of antipsychotic drug action and explain how evidence-based practice guides antipsychotic use. To explain how the sales trends of antidepressants has changed since Health Canada issued black box warnings. To explain why it is simplistic to say that antidepressant drugs work by restoring serotonin activity to normal, to discuss how lithium is used in treating bipolar disorder, to discuss the consequences of drug treatment and mental illness, and to discuss the stigma associated with mental illness and Canadian strategies to help address these issues. So, mental illness is the second leading cause of human disability and premature death in Canada. And when we look at certain disorders, major depression actually occurs in 10 to 25% of women, nearly twice as many as men. So here in Canada, the Centre for Addiction and Mental Health, CAMH, is Canada's largest addiction and mental health teaching hospital. It's located in Toronto, and it is where many psychologists and psychiatrists, such as myself, are trained at, and is like the biggest and largest training facility. And really what we're looking at, there appears to be a correlation between substance use and psychiatric illness. What we mean by correlation is that we know that a lot of people that have been diagnosed with a mental illness also have issues with substance abuse. And these occur concurrently at the same time. Now, there is a link, but we are not always sure how that link happens. We know that those with mental illness have a higher incidence of substance abuse, but we also know that those with substance abuse also have a higher rate of a mental illness as well. Correlated doesn't necessarily mean one causes the other. It just means that they, a lot of the time, occur at the same time. So again, as we talked about CAMH being the second largest addiction and mental health teaching hospital in Canada, where we learn a lot, do a lot of research, and get a better understanding of mental disorders and the treatment for them. So, 70% of mental illness appear before the age of 25. That's a lot of people. And the rates of concurrent disorders are significantly higher among adolescents. And so really, drug and alcohol abuse disorders are linked to higher rates of treatment non-adherence and to lower rates of recovery, which when we talked about that co-occurrence of mental disorder and substance abuse, we know that when those occur together, there is a higher likelihood that someone is not going to adhere to the treatment regime, whether it be medication, whether it be therapy, and that equals lower rates of recovery. So when we talk about concurrent disorders, it refers to mental health and substance abuse problems as they occur together. And really the etiology of concurrent disorders, it's a complex, and it becomes a treatment challenge. So mental disorders, like substance abuse disorders, tend to be chronic and relapsing illnesses, meaning they happen and occur many times in someone's life. In schizophrenia, and to a lesser extent other psychological disorders, substance abuse is particularly prevalent. So we know that a lot of individuals with a diagnosis of schizophrenia also have a very high rate of substance abuse disorder as well. So in fact, people with mental disorders, the risk of substance abuse is 2 to 4 times as high in the general population. And when we look at tobacco and cannabis, it tends to be the two most abused drugs. So those with schizophrenia, the prevalence of cigarette smoking is 2 to 3 fold higher, so 55 to 88%, than in the general population. And cannabis follows tobacco as the most used substance by people with co-occurring psychotic disorders. And it is suggested that cannabis use can actually trigger psychosis and schizophrenia. So a lot of individuals, when we do the research and we take a look at first episode, which means the first time someone who eventually was diagnosed with schizophrenia, has their first psychotic episode, a lot of the times that co-occurs at the same time as using marijuana. And so really there are two proposed models of increased substance abuse among individuals with mental disorders. The first model, the self-medication model, it suggests that the presence of psychosis, which is really neurobiology, and the symptoms the person experiences with psychosis will increase the likelihood of drug use. The self-medication hypothesis suggests that people choose a particular drug that is effective in combating symptoms of psychosis. So if someone feels psychotic, they use something like marijuana in order to reduce those effects. So the symptoms are lessened with the drug, and it provides what we call negative reinforcement. And that is the lessening of the psychotic symptoms with drug use. Whereas in the second model, the primary action model, suggests that neurobiology of psychosis and the brain areas involved increases a person's vulnerability to substance use. So, they have the psychotic kind of etiology, and that increases somebody's likelihood of using marijuana. So the person has an increased genetic vulnerability and then the shared neurobiological pathways for both psychosis and increased drug use. And that increased vulnerability may produce increased pleasure with use, which then provides positive reinforcement. So the positive reinforcements is the experience of pleasure. And really both of these hypotheses are actually supported in the Canadian research. So here we have a really good chart that kind of takes a look at the two models to explain the co-occurring psychotic and substance use disorders. So in the self-medication model, we have the neurobiology of psychosis, and then we have the symptoms that co-occur with psychosis, and then, substance abuse and vulnerability added to that, which then gives that negative reinforcement. Okay, it removes the symptoms. In the primary action hypothesis, neurobiology of psychosis begins, and then the symptoms of psychosis and substance abuse vulnerability occur at the same time, and that creates positive reinforcement, where the symptoms of psychosis, when they occur, and the substance abuse vulnerability, the substance use itself, creates the positive effects that reduce the symptoms, adding to a positive reinforcement. So before the 19th century, mental illness involved really the thought that there was a magical or religious explanation, such as demon possession, or a biophysical explanation. And that is really where things focused on mental illness as an illness with neurobiological causes and underpinnings that had beneficial results. So it helped promote the development of new treatments and reduce the stigma, that may arise as a result of magical or religiously determined theories of mental illness. And it actually encouraged investment in research, treatment, and care. So the concern about stigma is it has an important impact on people with mental illness, and it has increasingly been addressed with public education campaigns that equate mental illness with any other illness of the body, exactly the same. And I think that encourages an investment in research, treatment, and care, and helps reduce the stigma. But there are criticisms of the medical model. So according to the medical model, a patient appears to with a set of symptoms, and then based upon those symptoms, a diagnosis is made to determine what disease the patient has. And then once the disease is known, its cause can be determined, and then you can be provided with a cure. So in general terms, the argument for and against a medical model of mental illness are similar to those for and against a medical model of dependence that we learned in chapter 2. So for an infectious disease like tuberculosis or syphilis, the symptoms suggest a particular disorder, but a specific diagnostic test for the presence of certain bacteria or antibodies is then used to confirm that diagnosis. It then identifies the cause and clarifies the treatment approach, and once the infection is cleared up, the disorder is cured. But for mental disorders, a set of behavioral symptoms is about all we have to really define or diagnose that disorder. And so a person might be inactive or not sleeping or eating and quiet, and while little is said, might be quite negative. And that behavior might lead us to then call the person depressed. Does that mean that the person has a disease called depression with a physical cause and potential cure? Or does it really only give descriptions of how he or she is acting? In the same way we might call somebody crabby or friendly or nerdy. And so, the prevalence of perceived distress, which can precede clinical diagnosis, is assessed by, the Ontario University and College Health Association. So in Ontario, a survey of 25,000 students at colleges and universities in 2016 revealed increased rates of anxiety, depression, and suicide attempts since the previous survey that was done in 2013. So mental illness often affects thinking, mood, and behavior, and can be associated with distress and an impairment in functioning. And the symptoms can vary from mild to severe and may require sometimes hospitalization. And so really for mental disorders, a set of behavioral symptoms is all we have to define or diagnose the disorder. And so in that campus survey, 33% of undergraduate students self-reported 4 or more symptoms indicating or elevated distress. And 1 in 5 Canadians will have a mental health problem at some point in their lives. And so really when we look at the cross-section of that survey, mood disorders end up being one of the most common mental illness. And so despite, some of the attacks of the medical model, it's overuse of diagnosis, of this idea that there can be a cure to somebody's depression, or the overuse of pharmaceuticals in order to treat those, it still guides current thinking about behavioral disorders. And so really mental health or addiction will impact 1 in 5 Canadians. And I think anybody who's seen the Bell Let's Talk will know that statistic, 1 in 5 Canadians. And really that means anybody can be affected. And, people may discriminate, but mental illness and addiction does not. It crosses all socioeconomic strata, both all sexes, all gender identities. It does not discriminate. Everyone has an equal opportunity in getting a mental disorder, 1 in 5 Canadians. Although there is research to show that there are certain populations and certain environmental factors that will lead to an increased rate of certain mental illnesses. So here we look at, the percentage of inpatient hospitalizations by province. Okay. Mood disorders, again, dominating across all provinces for the most part. And some data from Manitoba not existent, same as Nova Scotia. But when we look at substance use disorders, you can see quite a co-occurrence along with mood disorders, and then schizophrenia itself. Okay. So when we look at the classifications of mental disorder, the APA's Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, we are now actually have a new iteration of that, the DSM-5 TR, which means text revision, which means some diagnoses have changed slightly, but the categories have largely remained the same. And it includes hundreds of specific diagnostic categories, and it is the widely used classification system. Okay. When we look at psychotherapeutic drugs, they really are drugs that are prescribed for their effects in relieving symptoms of anxiety or depression or other mental disorders. Doesn't always cure, but it can help the patient, reduce those symptoms, and hopefully in combination with therapy, help them live a more productive and stabilized life. So when we look at anxiety disorders and phobias, anxiety really is normal and common in human experience. The anticipation of potential threats and dangers, it often helps us avoid them. And a certain amount of anxiety or stress can happen before you take a test, before you engage in something new. And so the issue then becomes, a lot of times in public we say, I'm anxious. And the question is that anxiety, or is that a normal way of reacting to certain situations? If I am scared, if I'm going into a new situation, I might have a certain level of anxiety. But at times worries can become unrealistic, and that results in a chronic uneasiness, the fear of impending doom, bouts of terror or panic that then end up interfering with daily life. And I think that's one of the main things that you will see across a lot of diagnoses is that feeling, such as anxiety or let's say depression, is it reoccurring? Is it long enduring? And does it interfere with daily life? So physical symptoms associated with activation of the autonomic nervous system, that fight or flight, can include flushed skin, dilated pupils, gastrointestinal problems, increased heart rate, and shortness of breath. And so those are some of the physical symptoms when that anxiety is increased through the autonomic nervous system. So when we look at the DSM-5 and we look at the cluster of anxiety disorders and phobias, they are classified into agoraphobia, specific phobias, and social anxiety disorder, social phobia, panic attack, panic disorder, and agoraphobia, specific phobias, also known as simple phobias, and social anxiety disorder. Okay, and really, anxiety disorders, the whole cluster, are characterized by this idea of having excessive worry, fears, and really avoidance. And so when we look at the 1-year prevalence of that cluster of anxiety disorders in Canada, specific phobias, 6.2% to 8%, and social phobias, 6.7%, are the most prevalent anxiety disorders in Canada. And so when we look at general anxiety disorder, we're looking at 1.1%, and panic disorder is 0.7%. So those specific phobias and social phobias tend to be the most prevalent anxiety disorders in Canada. And so, again, that anxiety is normal. It's common in the human experience. And it can be associated with the physical symptoms of flushed skin, dilated pupils, gastrointestinal problems, increased heart rate, and shortness of breath. Okay, so we look at panic attacks specifically. They include shortness of breath, dizziness or faintness, palpitations or accelerated heart rate, trembling, sweating, the feeling of choking. There might be a feeling of fear of dying or numbness, or fear of going crazy or doing something uncontrolled. Okay, and those are the typical symptoms that we are looking for. Okay. And so when we look at the overview of panic disorder, this illustration involves the involvement of repeated anxiety episodes in panic. And it shows the developmental stages of the course of panic. So the precipitating variables that affect its course. And some of the central sites hypothesis to be involved in panic disorder. Okay. And really, repeated anxiety, which is in part 1, which you have repeated anxiety, which looks at age of onset, illness in family, how long the panic duration is for, its frequency and its severity, can create a major affective disorder, which turns into panic disorder. And that can create common disturbances. Okay. There can be, uncomplicated, which looks at mild depression or severe depression, mild phobia, hypochondriasis, or severe avoidance. Okay, while depression may lead to further increases in anxiety itself. When we look at obsessive compulsive disorder, we are looking at obsessions and compulsions. Those are the two main categorizers. So in obsession, it's unwanted and repeated thoughts, feelings or images, or intrusive, inappropriate causes marked distress. Okay. And then compulsions, which is really the urgent or repetitive behaviors such as hand washing, counting, or repeatedly checking to make sure that some dreaded event will not occur. Okay. And the individual with this diagnosis will have a hard time eliminating or stopping that obsession, thinking about it, or that compulsion actually engaging in those behaviors. When we look at post-traumatic stress disorder, or PTSD, it's really caused by when an individual has been exposed to an event that involves actual or threatened death or a serious injury. It's the first criteria that we are looking for. And the person then reacts with intense fear or helplessness, and then that person persistently re-experiences the event through recollections, dreams, sudden feelings as if they were actually occurring. And, PTSD is being recognized in war veterans, victims of abuse, and more recently, our Canadian first responders. And so, some of the diagnostic, there are, several diagnostic criteria, A through H for post-traumatic stress disorder. And really, the first is that there needs to be an exposure to actual or threatened death, serious injury, or, sexual violence. And then it will list of several of the ways in which that can occur. And then we go to criterion B, which shows that you need to have one or more of the following intrusion symptoms associated with a traumatic event beginning after the traumatic event occurred. So we're talking about reoccurring intrusive distressing memories, dreams, disassociation, and prolonged psychological distress, or a reaction to a triggering of physiological reactions due to that trigger that resemble an aspect of the traumatic event. It needs to be persistent avoidance. That's criterion C. And then negative alterations in cognitions and mood. So a mood change that is associated with a traumatic event. That's criterion D. Criterion E looks at marked alterations in your arousal and reactivity associated with the traumatic event. So irritable behavior, reckless, self-destructive behavior, hypervigilance, and then some of the other ones, F, G, and H criterion, are more focused on the duration, how long, the clinical distress that it causes, and that then the disturbance is not attributed to any other related physiological effect or of substances, so medication, alcohol, or another medical condition. So when we look at PTSD in the general population, you can see that correctional firefighters, police, paramedics, they are at a higher rate than the general population. Okay, in some regards higher than 3%, 3 times higher than the general population. It is because it is a cumulative thing, sometimes post-traumatic stress disorder, and so constantly being exposed to life-threatening positions or scenery can create post-traumatic stress disorder in an individual. When we look at psychosis, we are looking at a serious mental disorder, and it really involves the loss of contact with reality. And so we are looking at psychotic behavior, so a group of symptoms that can have possible causes, many different possible causes. Or an organic psychosis, really we're looking at one that has a known physical cause. So we're looking at brain tumors or infections, metabolic or endocrine disorders, degenerative neurobiological diseases, chronic alcohol use can create psychosis, and then high doses of stimulant drugs such as amphetamines or cocaine. Okay, or you can have functional psychosis where no known or obvious physical cause is happening. So schizophrenia is marked by one of the psychotic disorders, and it involves chronic psychosis characterized by delusions, hallucinations, disorganized speech and behavior, and lack of emotional responses. So the causes significantly interfere with social and or occupational functioning. So there's that phrase again. We're always looking for it to be. And really, the diagnosis of schizophrenia is characterized by two or more of the following. So delusions, which are irrational beliefs, hallucinations, such as hearing voices, disorganized speech that might be incoherent, frequent changes of topic, grossly disorganized behavior or inappropriate or unpredictable, or it can be catatonic, where you're withdrawn or immobile. And then you can have negative symptoms. So this is where we remove something. Lack of emotional response, little or no speech, and doesn't initiate activities. Again, it would interfere with social occupational function, and the duration needs to be at least 6 months. So when we look at schizophrenia in the brain, we are looking at different areas of the brain that would be involved in the diagnosis of the schizophrenia. And so the basal ganglia, the auditory system, the occipital lobe, the hippocampus, the limbic system, and the frontal lobe are all involved and affected by someone who has schizophrenia. And really, when we look at mood disorders, mental disorders are typically categorized by behavioral symptoms. For example, schizophrenia is characterized by delusions, hallucinations, and disorganized speech and behavior. And many successful people are now speaking out to show the diverse faces and lives of those suffering with mental illness, which does reduce stigma and show how likely these are happening in the general public. And so when we look at then another classification, mood disorders are characteristic by depressed or manic symptoms. Okay, and we have bipolar disorder or major depression. And symptoms don't always fit neatly into perfect categories. Okay. So when we look at mood disorders, it refers to the appearance of depressed or manic symptoms. So mood disorders have no single cause, but they have several factors such as biochemical imbalance in the brain, psychological factors, and socioeconomic factors that tend to make some individuals prone to such disorders. Okay. So, the important distinction in the DSM-5 and in the drug treatment of mood disorders is between bipolar disorder, in which both manic and depressive episodes have occur at some time, and major depression, in which only depressive episodes are reported. Okay. And so when we look at bipolar disorder, we're looking for a manic episode, which is really a distinct period of persistent, elevated, irritable mood, abnormal and persistent increased activity. So someone's going to feel a lot more elevated in their mood. It lasts for about 1 week, present most of the day. And then during that period of that elevated mood, the individual can feel like they have an inflated self-esteem, decreased need for sleep, like they only sleep 3 hours a day. They're more talkative. They have what's called flight of ideas, where they move from idea to idea to idea, almost like their thoughts are racing. They're very distractible. They have an increase in goal-directed activity, okay, whether it be socially, at work, or even sexually, or psychomotor agitation. So, purposeless or non-goal directed activity. And, the mood disturbance is sufficiently severe enough to mark impairment in social and occupational functioning, and it is not attributed to any physiological effects or substance. The important thing to note that for a major depressive episode, which again will not have that mania, you need to have 5 or more of the following. Okay, so depressed mood most of the day, nearly every day, diminished interest or in pleasurable activities, changes in body weight or appetite, insomnia or hypersomnia nearly every day, that psychomotor agitation, so increased activity, or retardation, so decreased activity, fatigue or loss of energy, that feeling of worthlessness, and that diminished ability to think or concentrate. And there can also be a diminished ability to think in concrete terms, and then ideas of suicidal ideation or even attempts. So when we look at the early treatment of mental disorders, we look in the early 20th century, where many psychotic patients were suffering from syphilitic infection, okay, of the nervous system, or general paresis, okay. And, in those days, a great proportion of the patients with psychosis had that paresis. And it was noticed that the fever associated with malaria often produced marked improvement. And so in 1917, malaria therapy was introduced in the treatment of general paresis. And the later discovery of antibiotics that could cure syphilis virtually eliminated this particular type of treatment. But we can see that there was symptoms, and they looked for a cure. They found out that those with malaria were being cured of their syphilitic infection. Until later on, things changed. But, in the 1920s, wealthier patients could afford a course of narcosis therapy in which barbiturates and other depressants were used to introduce sleep for as long as a week or more. In 1933, Manfred Sakel of Vienna introduced comas in some people with schizophrenia by administering insulin. And the resulting drop in blood glucose level caused the brain's neurons to first increase their activity and produce convulsions, and then decrease their activity and leave the patient in a coma. And so 30 to 50 of these treatments over 2 to 3 months was believed to be highly effective. And discharge rates of 90% were reported in the early years of insulin shock therapy. Okay. Later studies found out that there was a high relapse quality, and the treatment was later abandoned. But you can see that, there was an early understanding that something was happening and that there needed to be something applied in order to remove that mental disorder. And so when we look at early drug therapy, that's when we look again at that narcosis therapy, where depressants are used to induce sleep or try to, reduce the symptoms of a patient. Intravenous thiopental sodium that was used during psychotherapy to help patients with thought to express themselves more freely. Insulin shock therapy, which we just talked about. Electroconvulsive therapy, and it was incorrectly believed that inducing convulsions with drugs or electric shock would cure schizophrenia. And then the use of sedatives was used in severely disturbed patients in order to ease their treatment, ease their discomfort, and also make them easier to manage. And so really, the early treatment options, we had paraldehyde, which is a sedative. It was a major drug in the 1950s, and it was used for major disturbed patients at the time. Electrical convulsive therapy, seldom used now, though it's still a treatment option for major depression, and that it's persistent and drug resistant, bipolar disorder, and schizophrenia. But really, antipsychotic drugs right now are the first choice for those with the diagnosis of schizophrenia. And so really, when we look at antipsychotics and the discovery of phenothiazines, really they were called tranquilizers or neuroleptics or antipsychotics. And really, neuroleptic means taking hold of the nervous system, really trying to change that or reduce that. And so antipsychotics reduce psychotic symptoms without causing that sedation feeling that we would have saw in early tranquilizers. And so following the introduction of drug therapy, restraints and treatments like convulsive therapy were reduced and discontinued among hospital patients because of how invasive they were. And really, they saw quite a bit of relapse and reoccurrence. And so multiple rounds of ECT would be necessary. And the effects of ECT, such as memory loss, severe memory loss, actually, ends up being, one of the last resorts even today for treatment of something like depression or bipolar. And really what happens is, when we start looking at phenothiazines, they were found to be more effective than a placebo. So, 2 groups were given, one the phenothiazine and the other a placebo. And they found that those with the phenothiazines were found to be more effective in reducing their symptoms. Patients, though, however, relapsed when therapy was discontinued. And so there are 2 groups of antipsychotics. There's the conventional, which is first generation, and they were introduced before the mid-1990s, and atypical or second generation, and they've been introduced in the last, let's say, 10 years. And really, second generation antipsychotics are not without really side effects, which is always something that you're going to talk to a patient about to see, what are the pros and cons, benefits of those. And so Zeldox, it's really a serotonin and dopamine agonist, and it's used to treat hallucinations and negative motivation and really social withdrawal. And aripiprazole and paliperidone and zaprazodone are available in Canada for the treatment of schizophrenia and related psychotic disorders, and are typically the first level of antipsychotics. And so really what we're looking at is antipsychotics produce pseudoparkinsonism, indicating a link to what we call the dopamine receptors. And so really there is a time delay in the drug effect, and that indicates that the mechanism of action is probably way more complex. And so atypical antipsychotics, they block both D2 dopamine and 5-HT2A serotonin receptors. And so really what that does is it produces less pseudoparkinsonism. So when we look at the side effects, they are safe and that they are not addictive and they are difficult to use to commit suicide. But there are some side effects. There are some allergic reactions such as jaundice, yellowing of the skin, issues with the liver, skin rashes. There can be photosensitivity, easily sunburned. Okay, you can get a low white blood count that needs to be monitored. There could be what we call movement disorders. So you get tremors, you get muscle rigidity, you get a shuffling walk or a mask-like face, and tardive dyskinesia. And so when we look at the risk of antipsychotic medications in Canada, we look at some drugs in depth. Thioridazine it has been used in Canada for the treatment of schizophrenia since really 1959. And the brand name was Mellaril. And, in July 2000, Novartis Pharma Canada, the manufacturer of that medication, distributed a letter to Canadian healthcare professionals that discussed potentially life-threatening changes in heart rhythm caused by that medication. So in response to these safety issues, and as requested by Health Canada, Novartis withdrew the drug from the Canadian market in 2001. And so Health Canada issued an advisory that sales of thioridazine were to be stopped in 2005. The safety concern, really when we're looking at the benefits versus the risk, arose from rare occurrences of heart rhythm changes that could have been life-threatening. And so, according now to a Canadian survey, 89% of developmental pediatricians and 94% of child psychiatrists, they really prescribe what we call atypical antipsychotics. Commonly prescribed drug now was risperidone. And so really, the long-term effectiveness recommendations for the treatment of schizophrenia, they're really based on the scientific evidence developed by the Schizophrenia Patient Outcomes Research team in the United States, and it's based on exhaustive reviews of the treatment outcome literature. Okay, and so level 1, we're looking at evidence of systematic reviews and meta-analysis. Level 2, we're looking at evidence from at least one RCT. In level 3, we're looking at evidence from controlled trials without randomization. In level 4, we're looking at evidence from case-controlled or cohort studies. In level 5, we're looking at evidence from SRs or of descriptive and qualitative studies. When we're looking at level 6, we're looking at evidence from a single description or qualitative study. And then, we're looking at level 7, which is evidence from the opinion of authorities and the reports of expert committees. And so, level 1 was obviously looking at your Cochrane systematic reviews, which are the most thorough, and it goes down from there. So when we're looking at the long-term effectiveness, even patients experiencing success tend to stop taking the drug a lot of times. And this is a big problem when it comes to the treatment of psychotic disorders, that once the psychotic feelings, the perceptual disturbances or some of the symptoms are resolved, the individual stops taking the medication thinking that they're cured. This happens a lot. And so short-term efficacy exists, but long-term appears to be considerably lower because of this fact. And really, there's no clear evidence that atypical antipsychotics work better than the conventional ones. And when used in children, there is a high risk of weight gain and metabolic changes. So some really long-term effects there. And elderly patients with dementia have a significant increase in death risk from cardiovascular and other problems associated with antipsychotics. And so when we're looking at hospitalizations for schizophrenia in the general hospitals for 10,000 people, you can see that middle age bracket between 18 and 59 tends to be the highest. So when we move on to depression is a serious debilitating disorder that often responds to antidepressant medication. And there are 3 different types of antidepressants. There's monoamine oxidase or MAO inhibitors. Okay, so phenylazine and tricyclamine, bear with me with the pronunciations of these. Tricyclic antidepressants, so amitriptyline, doxepin, and nortriptyline. And then your selective serotonin reuptake inhibitors, SSRIs, so fluoxetine, sertraline, and venlafaxine, which are typically more now your first level that your doctor would prescribe for you if you're feeling, if you're being diagnosed with depression and to be treated with medication. But there are risks to antidepressants. So Health Canada does have warning labels that antidepressants can trigger suicidal thoughts in 2 to 3% of children and teens taking them. And so when we look at antidepressant drugs in Canada, these are just some typical doses and the types that, you see your MAO inhibitors, your tricyclics, and your SSRIs. And then there are several others that are Wellbutrin and such that are considered others. So when we look at monoamine oxidase inhibitors, it was discovered when a drug for tuberculosis was found that also elevated mood. And what it does, it works by increasing the availability of serotonin, norepinephrine, and dopamine. Okay. Now it has limited use because there are side effects due to toxicity. And so users must avoid certain foods and drugs in order to prevent severe side effects. So currently there are 2 MAO inhibitors are available in the Canadian market. Phenylazine and tricyclamine are managed by specialized mood disorder clinics. And so a limitation of MAOIs is their alteration of amino acids metabolism of dietary amino acid triamine. When we look at tricyclic antidepressants, it was discovered when researchers were working to create a better type of MAO, found that the drug did improve mood. And really, we're thinking that it may work by reducing the uptake, how much of norepinephrine and dopamine and serotonin your brain reuptakes, which means it releases a certain amount of norepinephrine, dopamine, and serotonin, and what is left over, it reuptakes or sucks back in to reuse, and it apparently reduces by reducing that uptake, leaving more in your actual brain. It's not effective in all patients, but it does reduce the severity and duration of depressive episodes. And so when we look at SSRIs, they work by reducing the uptake and therefore increasing the availability of serotonin in the brain. It is safer than the tricyclic antidepressants and is less likely to lead to overdose deaths. But it only has a little more effect than placebo in some studies, and a strong warning from the FDA about an increased risk of suicidal tendencies in children and adolescents, which will constantly have to be monitored. And with all of these medication combined with therapy always provide the strongest outcomes. So when we look at antidepressant mechanism of action, really it appears to work by increasing the availability of norepinephrine or serotonin. Okay. The one thing to know is that it does take time for that mechanism to begin in the brain. And so there is a lag period before improvement in mood is seen. And so typically I tell my patients it's going to take some time for it to build up enough in the brain in order to begin that slowing of the reuptake process. And so, we really don't have a complete picture of how antidepressants work. I will post a video on SSRI specifically because it is still a theory. It is how we expect them to work, but we just don't fully know. So really when we look at how Canada decides how drugs are sold and which professionals may prescribe is determined at the provincial level. But doctors and psychiatrists, MDs can prescribe. Psychologists and therapists such as myself cannot prescribe. We deal more with the therapy, but as I stated earlier, drug therapy in combination with medication always provides the best results. So educating the public is a first step in reducing stigma and encourages acceptance of mental illness. And so when we look at the rates of hospitalization for major depressive disorder, you can see that ultimately that the trend is it's going down. Many countries, they're reducing the number of beds and are moving towards closing psychiatric hospitals and replacing institutional care with really community-based mental health services. So getting people back into the community, into a less strict setting where individuals can learn how to manage the stress of their mental illness in the public. So when we're looking at ECT, it is the most effective treatment in relieving severe depression. Okay, it works very rapidly more quickly than antidepressant drugs. Okay, it is the best treatment choice in cases when there is a high risk of suicide and there's a lack of ability to use certain medications. And it can be used in conjunction with drugs. When we look at mood stabilizers, lithium was approved for sale in 1970, and early studies have found it to be effective in people with the manic episodes. The acceptance was slow in North America because there was a previous history of poisonings and a low perception of the seriousness of mania. It really wasn't considered to be that big of an issue. But it can be safe or toxic. So blood levels have to be monitored with mood stabilizers. And again, there is a high rate of non-compliance, especially when we're looking at bipolar 1 or 2. Individuals start to feel better and they come off that medication, which at times can then make a reoccurrence of that mania or those symptoms. And really what lithium does is normalizes the mood in bipolar patients and prevents both mania and depressive mood swings, okay? But it does have little effect in treating unipolar depression. And so other medications, such as anticonvulsant drugs, can also be used for the treatment of bipolar. Okay, so when we look at the consequences of drug treatment for mental illness, the number of people in mental hospitals has declined dramatically following the introduction of drugs that then control the symptoms of schizophrenia to a greater degree. And when we look at the greater increase of outpatient community mental health programs that were set up to treat patients closer to home and more natural environments, they end up becoming more or less expensive. But I believe that it also creates this, we are going to treat you as close to the real world as possible, so that you learn how to manage the stresses in the public, create those social connections that we know that are so important in the treatment of mental disorder, as isolation and stigma can really have a profound effect on someone's treatment, the treatment efficacy. And so, more mentally ill persons are jailed each year than are admitted to state mental hospitals. And about 1/3 of all homeless people have a serious form of mental illness. And so we can see that correlation. One does not cause the other, but they are happening at the same time. And really we are talking about, stigma that's associated with mental illness. And so heart disease, as it says in the line, is just another excuse for lazy people not to do work. And that's just not the case, right? The stigma attached to mental disorder and illness presents a serious barrier, not only to diagnosis and treatment, but also to acceptance in the community. And really, when we look at the Canadian Alliance on Mental Health Illness and Mental Health, they've identified combating the stigma of mental health and preventing discrimination against people with mental illness as one of the most pressing priorities for improving the mental health of Canadians. And so, in summary, diagnosis of mental disorders is difficult. The DSM does provide some, standard diagnostic approach. Panic disorders evolves following repeated exposures of depression and anxiety. Treatment of panic attacks depends on clinical history and brain regions that are involved. The medical model, of mental illness has been widely opposed. Mental illness cannot always be equated with other illnesses of the body. Psychotherapeutic drugs are often discussed in the context of the medical model. And antipsychotic were introduced in the mid-1950s and started a revolution in mental health. Antipsychotics, really are helpful for the majority of people that are diagnosed with schizophrenia and are widely prescribed, and they often produce movement disorders, some of which resemble Parkinson's disease. Okay. The first antipsychotic drugs used to treat schizophrenia were clopramazine and phenothiazine. And phenothiazine treatments had a tremendous impact on the management of hospitalized patients. Chlorpromazine is a typical antipsychotic drug. Clozapine is an atypical antipsychotic drug. Antipsychotic drugs are thought to reverse neurotransmitter system changes underlying schizophrenia. There's limited data on the efficacy on antipsychotic drugs in children, adolescents, and older adults. Typical and atypical antipsychotics are associated with increased risk of death in older adults. The major group of antidepressant drugs are the MAOIs, the tricyclics, and the SSRIs. Many antidepressant medications work to increase serotonin and norepinephrine levels in the brain. Other antidepressant medications work through different biochemical pathways. Prozac quickly became the largest selling drug in Canada. Black box warnings by Health Canada result in fewer prescriptions and increased suicide rates. Lithium acts as a mood normalizing agent in people with bipolar disorder, preventing both manic and depressive episodes. And the number of Canadian people in Canadian prisons and on the streets with a mental illness is increasing year over year. And the stigma attached to mental illness presents a serious barrier to diagnosis and treatment.